talk about something that's really close to our hearts, which is continuity of care, and how it's going to be embedded in general practice across Wales through the new GMS QI project. So here's what we'll be covering today. We'll be starting by defining continuity of care, then look at why it matters for patients as well as us as GPs. We'll walk through the aims of the QI project, introduce you to the RCGP Continuity of Care Toolkit, and outline what we hope to achieve this year. So what do we mean by continuity of care? At its core, it's about providing consistent, seamless healthcare to patients over time and across different settings. It's not just about seeing the same GP, it's about building relationships, sharing information, and managing care effectively. Continuity of care is a critical element of general practice, particularly continuity of the personal relationship between patients and their GP. Many patients are looking to general practice as the keepers of their story, the clinician or team of clinicians that know them and their circumstances best. There are broadly 3 types of continuity of care. Today, however, we'll focus more on relational continuity. Relational continuity is about the ongoing relationship between a patient and their clinician. It's important to note that there are many healthcare professionals within the primary care team, and that GP might not be the best person to provide that individual's continuity. For example, a patient with diabetes or COPD might have the most contacts with the practice nurse, and they could provide the continuity of care needed. And then the nurse could ask for other members of the healthcare team to support the patient where needed. In addition, less than full-time working patterns mean that for continuity of care to work, often a micro-team approach is needed to be able to support the patients most in need of continuity. That's a small group of health professionals from within the surgery. We've got managerial continuity, which ensures care is coordinated across different services, and informational continuity, which is about sharing relevant patient information correctly. In the long term, we hope to embed relationship-based care into workflows by improving appointment and triage systems, extending consultations for complex cases, and leveraging IT infrastructure to support continuity. Our overarching aim is simple but powerful: to embed relational continuity of care into general practice in Wales. It isn't just a nice to have, it's a fundamental part of high quality care. We're focusing on continuity within individual GP practices to improve patient outcomes, build trust, and make things more cost effective for the individual practice. Continuity of care leads to better understanding of the patient's ideas and expectations, family circumstances, and the community structure in which the patient is living. This ultimately gives us the opportunity for a therapeutic relationship to flourish, enhancing the overall patient experience. When considering continuity of care, there's always a complicated interplay between the finite resources and the capacity the individual surgery has to offer versus the demands, needs, and access requirements of the specific demographics of the patients that we serve. Access is really challenging at the best of times, and prioritisation of the services is complex. Whilst maintaining good access to healthcare is the founding principle of the NHS, a singular focus on just improving the access of speed to a workforce with a finite capacity can have the unintended negative consequences of deprioritising continuity of care. The purpose of this project is to refocus and educate practice staff about the benefits of continuity of care, and then understand how to implement lasting positive changes for their individual patient populations. So moving on to our objectives, we want to improve clinical outcomes, reducing morbidity and mortality by enhancing relational continuity of care, focusing on preventative and value-based healthcare approaches. We'd like to address health inequalities, prioritising relational continuity for the vulnerable populations, including those with complex needs, to reduce disparities in healthcare across healthcare access and outcomes. And we'd like to enhance.
It's the continuity.
Hi. We'd like to enhance practice operations, embedding relationship-based care into workflows by improving appointment and triage systems, extending consultations for complex cases, and leveraging IT infrastructure to support that continuity. So looking at the evidence, I mean, the evidence is really compelling. Patients are more satisfied, they adhere better to treatment, they have lower mortality rates, and it's one of the best tools we've got to tackle health inequalities. Looking at this in more detail, we have increased identification of at-risk patients for cardiovascular disease and statin prescribing, improved diabetic control, better life-saving decisions with suspected meningitis, better care for patients with dementia. We're looking at 10% fewer hospital admissions, 35 fewer episodes of delirium, and 57% less episodes of incontinence through the papers and evidence that we've been provided. Continuity is associated with developing trust between patients and their GPs, reducing anxiety due to a sense of security, and then we've got trust enabling earlier disclosure of symptoms and patient concerns. We've got an improved adherence to medical advice and prescription medication, which leads to a reduction in medicines waste. And then the uptake of personalised preventative medicine increases, such as screening and vaccination. So it's also better for us as staff of the NHS. For us as GPs, continuity does reduce workload over time. It improves job satisfaction and it lowers the costs across the system. So looking at this in more detail, we know that it also lowers the rate of attendance at emergency departments with physical and mental illnesses. We know there's greater GP job satisfaction leading to improved GP motivation. Over time, it reduces the workload in practice. It's faster and safer for clinicians requesting a test to process the results of the test. The time in between patient consultation tends to lengthen, on average by 18%. There's a reduction in consultations needed by each patient by 5%. There's lower costs in the whole system, less overuse of medical procedures. It lowers mortality rate across patients, which is probably the most interesting finding. There's actually a dose-response relationship shown between continuity of care and mortality. It reduces complaints and litigation. There's a reduced collusion of anonymity. The clarity of responsibility reduces the risk of patients becoming lost between clinicians. Continuity of care is one of the best current options for reducing health inequalities, as I've mentioned before. So just bringing that into a Wales-specific context, this is the summary of the Time to Talk survey, which was run by Public Health Wales in February this year. The survey covers full spread of demographics across Wales with 2,137 participants, gives us a good snapshot of public opinion in Wales. So in summary, most patients value continuity for ongoing conditions. We've got and patients in more deprived areas have a higher preference for continuity of care, especially if that care is ongoing conditions. This suggests trust and familiarity are more critical in deprived communities. In general, women value continuity more than men across all scenarios, but even more so in ongoing conditions. Men do tend to deprioritise continuity, especially in emergency situations. Older patients place highest importance on continuity in all contexts. Younger patients, those aged 16 to 29, are least likely to prioritise continuity, especially in emergencies, which reflects the greater complexity and frequency of care needs across an older population. So in summary, continuity is especially valued in deprived areas by older people and by females. I will now hand over to Rowena to take you through stage 1 of the RCGP Continuity of Care Toolkit.
Brilliant. Thank you, Claire. So we've got the evidence for why this is important and why it works. The key question that I think all of us as GPs in Wales want now is, how are we going to approach and evidence this as a QI project? Hopefully this will help. The RCGP has developed a toolkit which has got extensive resources that we can use to educate our staff and patients about continuity of care. So the toolkit will support practices to investigate their population and their practice needs, and then help us all to develop a plan to make positive changes and then evaluate the outcomes of that. The good news is our toolkit is free to access. You don't have to be a member of the college, although of course we'd like you to be. And it covers a wide range of tools, from patient surveys through to process mapping tools. And what we recommend is that each practice uses the step-by-step process to evaluate their current standing and then look at the steps that you can make to improve. So what do we have to do this year? That's all we're going to focus on at the moment. The contractual aims of this project for 2026 is looking for practices to show they've reviewed from step 1A to 3A of the toolkit. So of course we can all look through the whole thing for inspiration and see where we're going over the next 5 years. But for some of us, a step-by-step approach might feel more manageable. The key thing to recognise at the start is this is about our whole practice teams being involved and talking about continuity. So we want to be able to demonstrate our current understanding of continuity of care and how that can be improved. And that's looking at staff within the practice and for patients. We need to make sure that all of our teams know what continuity of care actually is, think about what our practice's current state of continuity is, and look at the enthusiasm our teams have got to build on this and see where we can improve. Second part will be to demonstrate what our staff and patients think is important in terms of continuity of care. So think about what helps within your practice, and then probably just as importantly, where the barriers are, and then agree together an aim for how to work towards improving this. And then thirdly, we want to be demonstrating ways that we can measure continuity for the purposes of a PDSA cycle. So plan, do, study, act cycle, looking specifically at this. We need a baseline measurement. We need to identify focus areas to achieve our continuity of care aims for this year, and then understand what data we'll need to measure now, during the process, and then later. So starting out, increasing our appetite for continuity, step 1A is practice level discussions. So we can use questions to assess what our current level of understanding is. So first of all, back to basics, what actually is continuity of care? What are the different types that Claire's described earlier? And how does that differ from quality of care? You can ask, does the practice have a vision, which are aspirations for your practice? And if not, you may wish to create one. As an example, my practice, which is a split site small practice, has had a practice aim for the last decade, I think, of Y Valley practice, 2 surgeries, 1 aim, excellence in healthcare, bridging the Y. But I got thinking about this a bit more with this continuity of care project, and asked a couple of our medical students if they could a practice vision statement that included continuity. And of course, medical students, being as excellent and able as they are these days, they really delivered. And I like their aspiration. It certainly gives us something to work towards. But we need to consider whether our own practice's ambition for continuity of care fits with this. But I'll read them out because I do think they're really excellent. One student said, our aspiration should be to be the most trusted primary care team in Wales, where you know we're with you for every step of your health journey, from routine checks to life changes. We offer continuous, compassionate care delivered by a well-coordinated, multi-professional team working side by side with our patients and community. And I had to give them a clap for that, because that is definitely, I think, what we're all aspiring to, even if we're not able to deliver it every day. And the other student said something fairly similar. Our vision is to deliver continuous care that you can count on through a trusted relationship with your key clinician, supported by a compassionate, collaborative team. We're committed to co-producing health with you, ensuring seamless, personalised care every step of the way. And in doing so, we build healthier communities rooted in dignity, prevention, and practical partnership. So what we're hoping is for practices to see clear benefits to increasing continuity of care for their practice and for their staff and for their patients. And we've got the evidence there. So start thinking about how your practice can fulfill its accountable GP requirements, which are set out in the GMS contract now. So this infographic shows what Claire's already talked about, all the benefits offered by continuity. And the slide focuses on benefits for our patients. So patients not needing to repeat their story, having their life context appreciated. We've got international studies on the primary care medical home model, which show that practices offering continuous personal care have fewer medical errors, fewer duplicate tests, and overall higher patient satisfaction scores. And that's the same when the care is delivered by teams within a single practice, as well as by just one clinician. For the NHS, the advantages are reduced costs, reduced admissions, better health outcomes. And large-scale NHS data, looking at over 200,000 patients aged between 62 and 82, showed that if a patient saw their usual GP 2 more times per 10 visits, so it doesn't have to be absolutely every visit, hospital admissions for ambulatory care sensitive conditions fell by 6%. So that's really a proxy for better managed minor issues like exacerbations of UTIs or other chronic diseases before they escalate. Also, really important to consider the clinician benefits. There was a training article in Pulse recently that highlighted that most practice complaints stem from communication breakdowns, not usually from lethal errors. And it found that continuity helps avoid these communication breakdowns and so reduces complaints. And even in case studies which involve mild mishaps, we know that patients were more likely to accept an apology and not escalate to a formal complaint when they felt known and genuinely listened to by their GP. So what we know is that complaints are growing, there's more of them all the time, and they're a really significant source of stress for GPs and their teams. So it's important for GP retention because a complaint will often be the final straw for a GP who's burning out, who just can't keep going anymore. So all of this is sort of beneficial across the board. So moving on to step 1B, which is increasing your appetite for continuity of care. In practice discussions, we can use these questions to assess the current level of understanding. So start off with what are the general views of both staff and patients towards continuity of care in the practice at the moment. Look around and see if you've got potential champions of continuity of care. Be ideal to have both a clinical and a non-clinical person in those roles. And try and assess whether there's some resistance to continuity of care or change in any form, because we all know change is one of the biggest challenges for people in an already very busy and difficult job. A benefits and barriers exercise is really helpful to get this conversation going and make people feel supported to share their concerns. This can be in a practice meeting or an educational session. Really encourage everyone to share their statements about continuity. If they're confident, get them to say them out loud or written down on sticky notes. Try and think about categories that will help you to find the achievable wins. So the benefits we've talked about, improved outcomes, reduced admissions, stronger therapeutic relationships, better understanding of patient history and context, and enhanced job satisfaction. But the barriers are just as important, and they might include, for instance, less than full-time working patterns, which are so common now, high patient demand, workforce issues, lack of incentive or lack of continuity metrics are difficult. Appointment systems might be a really important barrier to look at. And of course, that constant tension between pressure for rapid access to having an appointment over relational care. And all of these things are important to explore rather than pretend that they don't exist. The continuity but exercise is a reflective tool that's embedded in the RCGP Toolkit, which is aimed to spark honest debate and dialogue between GPs and teams about these barriers to delivering continuity. So you can have people who recognise the importance of it and really want to make it work, but just feel so floored by the challenges that they have lots of concerns about whether it'll work. So if you can get together in a practice meeting or an educational session and encourage everyone to share their statements, you know, I'd love continuity, but and get that written down, and then you might well be able to challenge these barriers. So the person who runs the session would collate the answers on a whiteboard or put the sticky notes up on the wall, and that acknowledges those tensions. It brings them out of the shadows and into the open. It might well bring to the surface hidden frustrations or systemic constraints that people are just thinking this is never going to work. And really importantly, it explores emotional responses to the challenges with continuity, and hopefully shared, they become a bit less of a barrier. Looking at practical obstacles that prevent continuity in a day-to-day practice is really important. People feeling burnt out is probably one of the biggest barriers, and that needs to be acknowledging. The continuity but exercise is really effective because it normalises ambivalence. We know many GPs care deeply about continuity and recognise it's better when it's there, but just feel conflicted by the pressures. And the exercise builds a psychologically safe space, which might be particularly important for newly qualified GPs or GP registrars who've got concerns but don't feel quite able to share them in a big team like that. It can link personal experience to system change, and it above all encourages reflective practice, which is always really valuable for these situations. Moving on to 1C, this is where we have practice discussion exploring specific points that might be relevant for your own individual practice, because lots of us are going through particular challenges. A series of questions you might ask. Has there been a practice merger recently, or is one planned? Something like that would have a significant impact on continuity, and also create other factors like staff change fatigue. My practice has just gone through the EMIS migration, and I don't think I've ever felt so knocked sideways by something. So, you know, these issues will all impact on how well you're able to take on a big change like this. You want to look at what your practice population is like. Is it a multi-site practice? Patients from larger practices, so the equivalent of 7 full-time GPs, are on average less likely to see the same GP. Multi-site practices, you want to think, is there a central reception function? Do GPs rotate across the sites? Do patients rotate across the sites and have appointments in both places? You want to consider how stable your GP team is. If your practice has high use of locums, then that will impact on continuity. Look at the range of GP sessions. If the majority are working less than 6 sessions a week, a micro team or a GP buddy approach might be the solution. Does your practice use personal lists? Does it maintain an accurate usual GP field on EMIS? Practices with good levels of continuity usually work to personal lists and have an accurate usual GP field, so that might be something to look at. And then finally, look at what your patient churn is. How long patients stay at a practice will affect continuity considerably. So if you've got a large student population, you need to acknowledge that and make allowances. So, points to consider. You want to think about how practices book appointments and which appointments they are. So your booking process is probably the most important key factor to continuity. Does your process direct patients to their usual GP? You know, does your reception staff check or use a tool such as Ask My GP? Consider looking at how long your appointments are. So varying appointment length might be useful in providing continuity for more complex patients. Think about the average waiting time for an appointment. We know this is a real barrier. If your patients are already waiting 5 weeks to see a GP routinely, they may not want to wait 7 weeks to see the GP of their choice. So have a look at that. A good exercise is talking to patients in the waiting room. that will give you a good indication of how long patients would be prepared to wait to see their preferred GP. If you've got GP trainees or medical students in your practice, it's a really great exercise for them, getting them confident talking to people, and they've got a bit more time to get that nuanced answer that might just be the key to opening everything. Have you got a multidisciplinary team in place? So practice pharmacists or physios, social prescriber? Are they working out of the practice? If patients are shared across a team, then think how that team as a unit is able to provide continuity. Are you in a training practice? The way patients book to see the trainee GP will impact on continuity. And does your practice have a highly functioning patient participation group? That can offer insights and support on how to improve continuity. So there's a lot to be looking at in this first year. And now I think I'm going to hand back over to Claire.
Thanks, Rowena. That's great. So we're moving on to step 2 of the Continuity of Care Toolkit. And this stage is all about defining your goal as a practice and scoping out what your current situation is. And 2A specifically is about canvassing the opinion of both staff and patients about continuity of care. So there's lots of different ways to canvass opinion, and Rowena's already touched on some of them there, but I'll go into them a little bit more detail here. We really want to try and make sure this is a whole practice and whole community project. So getting opinions from staff and patients is really important. There's some fantastic resources on the Continuity of Care Toolkit to support you to do that. It's really actually a good opportunity potentially to get the medical students and registrars involved, because it can support their learning about quality improvements, which is particularly relevant in the undergraduate curriculum, particularly phase 2 and 3 medical students, or years 3 and 5 would find this interesting. You could start with a simple continuity survey for both your patients and your staff. There are examples of all of these different tools within the toolkit that we've provided. The continuity survey can help you canvass opinion, and the results give you an indication of the level of continuity experienced and how important it is perceived to be. The survey is useful to repeat and reflect if you plan on using those markers as your baseline measurement. It can help you to identify areas to improve upon and give an indication of the potential appetite for change. You could arrange a focus group. That's like a small group of 8 to 10 patients who come together to discuss a topic. In this case, it would be continuity of care. That would be in more detail discussions talking about their stories behind their answers, giving you really good qualitative data to discuss. And patients' words and stories are a better insight into the behaviours, and they're quite a powerful tool in shaping an improvement journey and bringing practice, staff and patients with you. This could be actually an important first step towards forming a patient participation group if you don't already have one. Working with patients is a really key element in improving continuity of care. Hearing the patient view on continuity at a practice level, PPGs differ in their views, reflecting the community that their practice is based with. So it can help with checking the clarity of messages of continuity of care communication materials. It can gather experience and expertise as a patient at the practice. It can garner their support with some of the tasks, encouraging other patients to complete the surveys. And if you're lucky enough to already have a PPG, you can use that group to get started on these activities already. Patients have found practices have found chatting with patients in the waiting room can be really insightful, as Rowena mentioned earlier. There is talking about what is an acceptable wait, and there's really good toolkits within the RCGP toolkit to get this process started. You could also consider the reception desk audit, where you audit patient behaviours when they're booking appointments and try to understand why patients choose not to book with their own GP. There is a template that you can use for this to undertake a short audit by the reception team over a week. And these findings can help the practice to understand why patients choose not to book with their own GP and what changes are needed to help and enable support continuity. So in step 2B, you are investigating the data and the processes that may help or hinder continuity of care. And in this point, you need to consider things like, What does the demographic data tell you about your practice and potential challenges? So, for example, if you've got a large student population, is your population quite deprived? What is the age spread of your patients? Is there a difference within the practice between individual healthcare providers or GPs and continuity? What is the difference between different GPs in the practice? Are there any that are particularly good at achieving continuity of care? And if so, what do they do differently? Are there particular cohorts of patients who would benefit from continuity of care? What does the practice do that encourages or discourages continuity of care? And consider where information about a patient flows in the way that GPs work. So, for example, to overcome less than full-time working, are micro teams or buddy schemes needed to improve this situation? So there's a few things to explore here. In the toolkit, you'll notice that there are links to English statistics and measurements. So obviously we'd like to make this more relevant to us in Wales. We've got the Public Health Wales dashboard and StatsGov dashboard that it's really worth looking at. If you haven't already had a chance to look through this, it provides a really good breakdown of patient statistics and trends over the last decade, looking at cluster level and practice level statistics. You can look at everything from the mortality rates, childhood screening, through to emergency admissions for individual conditions. And this could give you a good baseline measurement if any of these things are something interesting to look at for you. We haven't got specific continuity of care measures in Wales in place at the moment. However, we are going to be looking at bringing this out over the next couple of years through this project. So watch this space on that. Next, you could explore if there are any differences in continuity of care within the practice itself. Is there any variation between doctors and any healthcare professionals? It helps to then define what you want your focus of continuity to be. For some practices, this could be full personal list approach. For other practices, this could be looking at small groups of patients to see if you could make changes that would influence their health. The examples include the frequent attenders, end-of-life care, frailty, polypharmacy patient groups. Frequent attenders are going to benefit in particular as they will then not need to repeat their story as much at every consultation. The GP can build a picture of the patient with each consultation. You get a trusting relationship. It helps to avoid late or misdiagnoses. The Power of 3 resource in the toolkit will help to recognise these patients, and then it gives you 3 consultation types you could be looking at, 3 different types of patients, 3 possible measures, and it's checked at 3 monthly intervals. You can identify patients who have had a consultation 6 or more times in the past 3 months as a starting point and go from there. So palliative care group, often they're managed by palliative care teams or district nurses and they have a full package of care, but if this is not the case, they could be very well documented and continuity of care would be very valuable. But we could look, it could be quickly started in this group and a straightforward patient group to look at. Frailty, looking at a frailty index of greater than 0.36 or Rookwood score of 7 to 9. These would be quite frail and vulnerable individuals, and you could further define these groups by looking at how many times you're doing home visits, or risk admission scores or multimorbidity. Using the low frailty index score might be quite misleading though, as patients can have a high score but be independent and less happy with continuity. Polypharmacy, if looking at this group, we need to consider certain things like diabetics are likely to have at least 5 items. So looking at high parameters of greater than 10 items is going to be more beneficial. You would exclude things like dressings and appliances to prevent inflating the items artificially. Taking a pragmatic approach, perhaps focusing on patients at really high risk receiving 10 or more regular medications with other unfavourable factors such as contraindications, drug-to-drug interactions. Assessing the opportunity to provide continuity as a micro team, including the GP and the practice pharmacy. And the King's Fund Polypharmacy and the Medicines Optimisation is a really useful document in understanding polypharmacy and doing this as a baseline. Older patients, age on its own wouldn't be a good indicator of continuity of care. Some patients are really fit and resilient, but if you're using age, I'd combine that with another marker such as home, the patients who are housebound or they're a care home residents. So finally, you can consider process mapping, look at the practice processes and how they impact with continuity, understanding what actually happens, not just what's supposed to happen within the practice, breaking it down step by step. You can begin to understand the challenges and the opportunities for continuity of care, as well as avoiding duplication. So you can look at how we book appointments, how you can encourage continuity of care from that booking point, understanding how it can be honoured if requested, look at what the messages are given to the patients regarding continuity. How is the usual GP system used or not used? The access or availability of GPs, and including what popular GPs and how that impacts the process. And is there any manipulation by the patients of the system, which could be an indication that it doesn't work for them? The pressures on staff the pressures that staff are under, and how that impacts the process and the level of reception triage that occurs. We've got new patient registrations, understanding the difference between registered GP, usual GP on the patient record, process for recording both of those, how a usual GP is chosen, and considering what is in the patient welcome pack, for example, what message you give to patients about continuity or access when they join the surgery. How the clinics are set up, your diary every day, understanding the balance between the workforce, the GP sessions, the commitments, including your student times, trainees, locum use, how capacity is divided up, resource different sites, specific clinics, triage, and the variation of appointment types. The level of forward planning of the individual sessions as well. So test results are a really useful place to start. You could understand how tests are received. Is this automatic or through a manual direction? For example, many results now all return to a pooled GP or senior partner as the default setting. So thinking about how that could be reviewed, how we can improve continuity from that point of view and make it a manageable system. Who reviews the test and when? Who covers GPs when they're on leave? How test results are then relayed to the patients. Is this via admin or through any GP or their own GP or the GP who ordered the test? Is there sufficient information to avoid unnecessary appointments? You can identify any duplication or problems also through this. So prescriptions, understanding what the level of online and paper repeat prescriptions is, and the turnaround time that could be decided and the impact on continuity. The process for acute and hospital prescription requests in terms of who they're directed at and why. So finally, workflow, understanding what correspondence is recorded in patient notes and what required review is needed before recording into the notes, how correspondence required review is directed. So is that through the referring GP, the usual GP field, or the GP last seen or most seen? Is there any problem or safety concerns? For example, what cover is available when other GPs or clinicians are on leave, and the potential delays in acting on results? Are there any inefficiencies within this? So on the next slide is a table that you could construct to help you review the different processes and see if there are any changes you'd like to put in place as a surgery to help streamline things. So step 2C is about gaining consensus on what you're aiming for and sharing this vision as a practice. What is practice continuity of care? What are you aiming to start with? What are your main aims of focus? So are you going to pick a cohort of patients? Which types of continuity are you going to be looking at? Are you going to be looking at personal lists or micro team or a buddy approach? How will you share that aim and gain agreement in the practice? Are you how are you documenting that aim so everyone in the practice understands it? Who needs to sign off on it? So making sure that there is a lead to deliver that aim, and consider having both an operational and a clinical lead, and involving staff to represent the whole practice. You can complete a practice proposal like this one that's available on the RCGP Toolkit online. But we now have a sample poster that needs to be completed this year from a contractual point of view. So this has just been agreed and will be sent out to you all shortly. You'll notice there's a greyed out section on the left side. You can complete that this year if you want to, but it's not contractual to do so. It helps to plan for future years. There's a tick box section on the right side of the form, which asks you to confirm that you've completed all the elements, and only the sharing of the practice level data with the collaborative on a quarterly basis and the QI poster to be shared on the 31st of March 2026 needs to be evidenced. This sample poster is going to be shared very shortly, like I pointed out earlier. So I'll move on to stage 3 of the toolkit, which is the end point. It's measuring and understanding. This year, we're only contracted to go as far as 3A. So at the end of the exercises, you should be able to identify your improvement measures and listen to what the data is telling you now. 3A is specifically about understanding measures of continuity of care and how to use them. The questions below help to assess the current level of understanding. What are recognised measures of continuity of care? If starting out with continuity, could a named GP for a smaller number of patients to see if it reduces practice contacts in that particular group? It could be that you're looking at continuity flow of test results. It could be that you're looking at patient survey results. You need to consider which measures are going to be best for your practice as a whole and your continuity of care aim individually. Consider the continuity of care types and ways of working options. Which tool will help your practice measure continuity of care? And what is your level of continuity of care right now? For information only, these are the 3 most commonly used global measures of continuity of care in general practice. There's the UPC, or usual provider of care. This is a measure of how often a patient has been seen by the same GP over a period of time. The measure is for each patient who has had 2 or more consultations. Then we've got the SLIC, or the St Leonard's Index of Continuity of Care. This measure is for practices operating or moving towards personal lists, but it can also be useful for looking at small cohorts of patients. And then there's the Continuity of Care Index, which is a measure of dispersion of visits. This uses frequency of visits to each care provider. It rewards having fewer providers, which makes it a useful tool for micro teams. So in summary, this first year is just about preparation. We gave you an awful lot of data in that presentation, which you can look back, because obviously this will be recorded and we'll be providing the slides later for you to go through in your own time. It's really important that the whole practice comes along. So the focus should be whole practice involvement, educating everyone about continuity of care, staff and patients, understanding your patient demographics, and then developing a clear practice goal about continuity of care.